Metastatic breast cancer is a topic that needs so much more education and awareness. And I'm so honored to have Dr. Ramji Rajendran, radiation oncologist, my medical advisor, who I'm so grateful to have as part of my global mission to educate people from all levels of being diagnosed with breast cancer, from caregivers to early stage breast cancer like myself, or anyone going through metastatic breast cancer, to be empowered, informed, and aware of the advances being made with radiation. So, Dr. Rajendran, can you tell us a little bit about yourself and why you are a Learn, Look, Locate medical advisor?
Sure. So my name is Ramji Rajendran. I'm a radiation oncologist in a large private practice group in the Chicago area. I think we call it Chicagoland, so we'll go with that. Within Chicagoland, I work with 20 other amazing radiation oncologists that work through hospital systems throughout the city and the suburbs, and we take care of a lot of patients with breast cancer and a lot of patients with metastatic breast cancer.
And you are a Learn, Look, Locate medical advisor because
Honored to be so because I had the opportunity to work with some friends, and the more I am able to empower women, the more they're able to get, I believe, better care and able to advocate for themselves. And I feel that that's really the key, because knowledge is power. And the more power you have, the more you feel like you're able to tackle anything.
yeah, that's exactly kind of why I started this. I want to make sure everyone's aware of the advances being made, especially with radiation. I don't think radiation gets a lot of airtime, if you will. I myself went through 25, I guess you call it rounds, and was pretty fascinated with how radiation can kill the cancer.
So when we think radiation, we think about, I don't know, currently I would say the Chernobyl thing on Netflix, or we think about, the Cold War. There used to be radiation drills in elementary schools, where they hid under the table and that was your radiation drill.
Huh.
So, radiation is supposed to be scary, but modern radiation is more like technology. So you think about AI, you think about NVIDIA, and all the new technologies that are going to be coming aboard. And that's more like what radiation is today. It's the ability to take energy and deposit it within the body to treat cancer and spare normal tissues. So that is exactly how it works in stage 4 breast cancer, because stage 4 breast cancer means that the cancer has gone elsewhere. So often you can have patients that have metastases. These metastases either do not respond to other systemic treatments, or they are in areas where things like chemotherapy and immunotherapy do not go to as well, like the brain. And radiation is used to really focus the energy in those areas and be able to treat and get rid of, obliterate cancer in those areas.
Incredible. What about the advances that are going on with breast cancer treatment and radiation? I mean, so when I got my radiation 6 years ago, no, five, six, I can't remember. The machine's going around and
And isn't it great that you're actually losing track of time?
ah,
How long? Because that means
oh,
you're a survivor and a thriver. And yeah, you may have had radiation in the past for breast cancer, but that doesn't, you're living your life. And that's an amazing thing.
thank
But
you.
there are patients that, unlike yourself, who received radiation in the adjuvant setting to
Okay.
prevent recurrence of cancer. There are patients that have cancer that has gone elsewhere in their body, say
Hmm.
to the bones, to the lungs, to the brain. And those patients we are able to treat with focused doses of radiation. And if it's treated in the brain, it's called stereotactic radiosurgery. And of course, one of those ways is using the gamma knife, which is what I do specifically, but there are many ways to do it.
Hmm.
And in the body, it's called stereotactic body radiation therapy. And we have We love acronyms in medicine. So the
Okay.
acronym that we use for stereotactic body radiation therapy is SBRT, but that
Okay.
doesn't make a great name. So they actually also have an alternative name to SBRT called stereotactic ablative radiation therapy, which is called SABR, SABER, SABR radiation,
Okay.
not to be confused with cyber, which is cyberknife, which is a
Uh-huh.
way in which you can deliver saber. But, it gets a little bit confusing. But I think the keys to know are there are ways in which there are ways to deliver high energy radiation to small volumes so you can target the tumor while still sparing normal tissues.
So how does a person who's diagnosed with metastatic, they get the diagnosis, they find out they're metastatic. Is it their response? Well, obviously their healthcare team, but to understand if their cancer where they're being treated does not offer this type of advanced type of radiation, how do they go about finding this? This is what I want people to be empowered about.
So I think that for the most part, um, radiation oncologists in this country are able to offer most treatments available. And I
Okay.
think that for the most part, they're able to deliver the therapy anywhere in this country.
Hmm.
There are patients that may need to travel for up to an hour or more to be able to receive radiation in more rural America.
Okay.
But either in the urban or suburban cities, we're able to deliver radiation in the highest quality way. Um, and so most medical oncologists are familiar with how their radiation colleagues work. Most community hospitals also have a tumor board for breast cancer. That's always a great way to just check in with your doctors to make sure,
Hmm.
ask if they have a multidisciplinary tumor board and ask how often they meet. So that's a good way to see how your doctors are talking to each other.
Hmm.
Alternatives to that are that doctors talk on the phone and they text each other and they're able to communicate in that way as well. But a multidisciplinary tumor board is a good sign that all your doctors are working together.
Okay.
And in the setting of stage 4 breast cancer, everybody sees a doctor like the good Dr. Singh, a medical oncologist. And so I think that that's great. And the medical oncologists are always aware of ways in which to treat with chemotherapy and immunotherapy, but they're also aware of when a patient should be sent for radiation in if there's localized disease, specifically if there's tumors that are in the brain that
Mm.
can be seen on an MRI, or if there are tumors that are causing pain in the bones from bone metastases,
Mm.
or if there are tumors that are causing obstruction of an airway or major blood vessel, or if there's tumors that are causing bleeding. Those are all more on the emergency side of things.
Okay.
But
Okay.
even for bone pain, for example, patients may need to be on narcotics when, they may also benefit or require less pain medicine if they had some radiation to the areas where they're having bony pain.
So, Dr. Jenden, what is the most advanced type of radiation that's happening right now for the stage 4 breast cancer patient?
So I would say that in current practice, that would involve use of stereotactic radiosurgery for the brain and stereotactic body radiation therapy for the body. Uh,
Okay.
but are you also asking me what's next?
Yeah, sure. We
All
want to
right.
know.
All right. Well, what's not yet in clinical practice and really not yet in clinical trials yet, I mean,
Okay.
stage 3 clinical trials, but what is being developed in animal models and hopefully soon to be developed in people is both imaging and treatment with radioactive medicines.
Do tell, elaborate.
So we know that there are types of breast cancers that have overexpression of the estrogen receptor, right?
Yep.
So
Hmm.
there are patients and there are places that offer estrogen that is radioactive given to a patient for imaging where the radioactive or where the estrogen receptor positive breast cancer is. So you may have a biopsy from a primary breast cancer saying that it's estrogen receptor positive, but if you now have 20 metastases throughout the body, are all of them also expressing estrogen receptor? Would all of them respond to anti-estrogen therapy? Maybe, maybe not. So let's say that you have a way in which to image using radioactive estradiol. You can give that to a patient and do a
Wow.
PET scan, like a positron emission tomography scan, and be able to tell which of those metastases are still overexpressing estrogen receptor
Oh,
and therefore be targets for anti-estrogens, but there may be others that are not responsive or not estrogen receptor positive any longer, and they may be targets for stereotactic body radiation therapy as opposed to continued systemic treatment with just anti-estrogens.
whoa. As a survivor of estrogen positive breast cancer, let me see if I understand this so I can break it down.
Again, not in clinical practice yet. You know,
Okay.
I think it's important to know where things are. And so I
Okay.
am talking about where things are going.
Going.
So, it's we want to stay ahead of the hockey puck. And
Yes, which
that's where
is
things are going.
yes, and that's why I did this because I've been getting to know all of you doctors gets us in the know. So we're aware that there are incredible things going on.
But
Dr.
if
Rosen, yeah,
but if our, listeners go and ask their doctors,
for this,
hey,
it's not
I want an estradiol PET scan,
right.
that may not be available, and it
Not
may
yet.
not be available routinely as of
Uh-huh.
yet. But hey, this is going to be publicly available, and maybe in 5 years, people will be like, "Oh yeah, of course, an estradiol PET scan. Everybody's getting those now." So I want to talk about where we're headed because I feel
Yeah.
like that's always exciting, and it always gives me hope to see what new things are coming.
But I want to understand it. So let me break it down for us
Sure.
patients. So if I understood this correctly, what this can do is understand whether a tumor is responsive to, for instance, endocrine therapy. And then maybe some of these tumors, for someone who is metastatic, are not responding. So to make sure that you're covering all aspects of stopping the cancer growth, you've got a type of radiation to go towards those tumors that are not estrogen, feeding off the estrogen. There's some that
Right.
are, some that aren't, and
Right.
you will be able to tell which ones are and which ones aren't and where to.
That's where we're headed. That's the future.
That's incredible.
Yeah.
Thank you
And
for sharing that.
we now know that patients also on the flip side that are estrogen receptor negative, we know that patients respond to medicines like Herceptin and Perjeta, trastuzumab and pertuzumab, right?
Uh-huh.
We know that those patients can respond extremely well, and these are proteins that are on the cell surface.
Okay.
So there are studies looking at Herceptin tagged radioactive compounds that can be used to image those tumors, but also to give an injection of a radioactive Herceptin to then treat those HER2 positive cancers.
So to help us to understand, when you say an injection, that is literally like an injection. It is not
It's kind
radiation.
of like you're injecting, like you would get an injection of a chemotherapy or
Okay.
biologic therapy, But instead, you have a radiation molecule tagged to that medicine. So it targets with radiation from the inside of your body directly to those HER2 positive tumors. And that's called radiopharmaceuticals. And that, to me, is the most exciting thing coming up, which is not standard of care, not even in practice, not even in phase 3 or phase 2 trials yet, but the field is moving quickly, and I think we're headed that way.
And how will we know when this is available?
Oh, you'll hear. I mean,
Okay.
the investment in radiopharmaceuticals by large pharmaceutical companies has totaled over, I think, $6 billion over the past few
Whoa,
years.
whoa,
And the
whoa.
market for that is supposed to be over $40 billion in the next 10 years by 2030. So I believe that radiopharmaceuticals are going to be the next big thing in treating and, really helping those patients with stage 4 breast cancer.
Would this be in addition to chemotherapy or instead of?
I think that there is, we have seen so I recently read a book by Vince DeVita. He was the head of he is the main author of the textbook of hematology and oncology. So he is a gentleman that has been the head of the National Institute of Health. He's been the head of Memorial Sloan Kettering. He's been the head of Yale Cancer Center. And he developed the concept of using multiple chemotherapies to treat leukemia and lymphoma. And I think, in reading his book, it really seems to me the combination of things are probably the way we're headed. And I think the timing of things will also be important. So I think the more we learn about these new treatments, we have to fit them into how and when they would be used, and also what in combination. For example, initially Herceptin was thought to be given, or was going to be given by itself as a cure for breast cancer. It didn't really work. So they gave it with initially medicines that were like adriamycin, which is cardiotoxic, but they found that those patients had even worse cardiotoxicity because Herceptin is also cardiotoxic. So now Herceptin is given with chemotherapy, but not adriamycin. And so that took some learning, right?
Mhm.
That took some clinical trials and being aware of how these patients did. So as these medicines go from really right now animal models and early stage in human treatments, they're going to be brought to the forefront, and we're going to have to learn from clinical experience and clinical trials to optimally deliver them for the right patient at the right time. So it's a
Wow.
process. There is no, I mean, gosh, how I would love to be able to tell my patients, this is the next big thing. This is all you're going to need. It's going to be
Yeah.
over. The whole, battle is going to be over. However, it's going to, each one of these things is going to fit into the whole big picture
Okay.
of uh, a line of defense or an armamentarium against stage
Mhm.
4 breast cancer.
So, Dr. Rajendran, I'm still blown away by this estradiol PET scan. I know there's some more terminology in front of it, but can you walk us through just the whole concept again so we all understand? Because this is extremely
I
exciting, but
can't
not necessarily
I
again,
can't
but
bore your audience, Cynthia. I can't give you like the everyday rigmarole of radiation oncology. I got to make it exciting for you. So there is something called an F18 fluoroestradiol PET scan, and
okay,
that is a type of PET scan that uses radioactive estradiol injected into a patient and allows for imaging of areas in which there's overexpression of the estrogen receptor,
there we go.
including breast cancer metastases.
Okay, so when will this be available? We talked about this offline for a
It,
minute.
it is currently available in very select areas,
Okay, it is.
but it is. But it's, It's one of those things where it's a specialty test at this point,
Okay.
but we're talking about where we're headed, and I think that it's going to be. I think in general, imaging with radiation and therapy with radiation, meaning injection of radioactive compounds, will be used in addition to things like stereotactic body radiation and stereotactic radiosurgery for the brain. These are called, so they're medicines, right? So they're called pharmaceuticals, but they're radiation, so they're called radiopharmaceuticals. And
Side
I think,
effects. Sorry to interrupt.
oh, sorry. So side effects are very different than what we're used to, and we're still learning about them. So
Okay.
there are side effects to everything we do. Imaging is relatively safe, but if you're giving therapeutic doses of these medicines, then you can have radiation toxicity, and it depends on where the tumors are. So if the tumors are in the bone, then you're more likely to get a pain flare from radiation being delivered there, like you would if you delivered external beam radiation. But if you're near lymph nodes in the abdomen, you might get some nausea, you might get some loose stools, things like that. But I think we're still learning. Remember, these are
Okay.
not yet in clinical practice as treatments, but those will be discussed with your patient's physicians whenever this is available and whenever the appropriate treatments
But
are
it
given.
is safe. It is safe to use.
So, yes, it is safe, but there are, like with any treatment, there are side
Okay.
effects and there are
Okay.
risks. And the risks are potential toxicity to the bone marrow, there are potential toxicity to the organs that are close to wherever you're giving the radiation, just like any other radiation.
Okay.
And we're learning as radiation oncologists about how to do dosimetry from this.
Okay.
Because remember, you're giving the treatment, but you're also seeing where it goes and how much goes there. And there are ways in which you can then back calculate how much radiation you gave from the injection and see how much more you could potentially give from external beam radiation.
Wow. Okay. I'm just blown away. Thank you for this. This is really exciting. I mean, it's
I'm
wonderful to be
equally excited about this. I think radiopharmaceuticals are the future. And I
okay.
think that they're going to be, right now, they're being used predominantly in prostate cancer. But they're also being used in some gastrointestinal tumors.
Okay.
We're using them for imaging studies in the brain to look for patients that have tumor recurrence in the brain versus radiation necrosis. We have a clinical trial open at Alexian Brothers for that. Um,
Okay.
I mean, it's what's coming and it's what's next, but it's going to come in a major way. I mean, there's a huge
Okay.
investment of capital. There's a huge amount of technology being involved in this. And I think it's going to be a lot of fun to be on the front lines, and it's
Yeah.
going to be ultimately very beneficial to patients.
Is the US going to be the first to bring this forward, or any other
Oh,
countries
no,
doing it?
no, 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 no,
No.
no. We are uh,
Behind?
an international, no, 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 not at all, not at all. We deliver, I would say the US has the best overall healthcare system in the world, and that's why I'm proud to work here.
Hmm.
But I also feel that there are countries that are leading the way with
Okay.
radiopharmaceuticals, and those are just specific institutions. Like Germany has two institutions that do a lot of this. The Australia has a lot of has one major hospital that does this, but we
Okay.
have Mayo Clinic is starting to do a lot of radiopharmaceuticals. In Chicago, we have a neighbor called right in Grand Rapids, Michigan, called the Banff Clinic,
Okay.
BAMF, and that is a clinic that does a lot of clinical trials with radiopharmaceutical imaging and treatment. That's a place where I'll be um, touring next week and hoping to work
Wow.
soon.
Okay.
So, yeah, I mean,
Cool.
I'm really into this. I think this
Yeah.
is the
Yeah.
future, and I'm very excited about it.
I'm probably the extreme on the survivor side that's into it too.
Yeah.
I find this part of what I do to be really exciting because, as Dr. Rosen, Senior Medical Advisor for Learn, Look, Locate, always says, it's a very exciting time to be a physician with breast cancer right now because I think it's important that people who have gone through this understand the amount of work that's going into the advances for treatment.
Right.
And I want to bring that forward because we celebrate the physicians and all of your hard work towards this difficult time. So I'm
It's,
really,
yeah, it is. And, especially treating patients with stage 4 breast cancer,
yes,
that is a
yes,
difficult thing to do as a physician.
yes,
There is burnout, there is a toll that it takes. There are patients that are my age or younger that are, suffering, and
yes,
it's hard to see. So you
yes.
can't help
I've
but
lost
envision your family in that situation. So,
I've lost too many in my journey here with Learn, Look, Locate and way too young. So this page here
sorry.
and this interview is priceless and hopefully extremely important. I'm going to move on to brain metastases and breast cancer, if that's okay, because
Sure.
it seems like that's where, help me to understand, that's where sometimes, or the predominant place where this might go. Is that correct?
I would not say that it's the predominant place for this.
Okay.
I would say that uh, brain metastases can occur with breast cancer.
Okay.
It is something that happens, but it is not the number one site where the tumors can go.
Is it
Typically,
lung?
breast cancer goes to the lymph nodes first.
Lymph nodes.
It
Okay.
can go to the lung, it can go to the liver and other solid organs, and it
Okay.
can go to the bones.
Hmm.
Um, but it is brain metastases are a very significant and severe form of of metastases.
Right.
Um, the treatments for those include surgery with neurosurgical colleagues, include
Okay.
whole brain radiation, and we do give whole brain radiation sometimes with sparing the hippocampus, which is a structure for long-term memory preservation. And the third way to do it is with stereotactic radiosurgery. Specifically at our hospital, we have a gamma knife, so we use that technology. And I think that's, been very, very effective for my patients.
Mhm.
But these come with consequences. I mean, our patients, it's almost like a relationship. We see them every 3 months for the rest of their lives with an MRI of the brain. That doesn't mean they get treatment every 3 months. They just are seen and reviewed. And
Yeah.
sometimes we have to treat them more than once. So, and sometimes it's hard to interpret the MRIs. Does a patient have recurrence, or do they have effect of the radiation that we gave? And so that's why we're doing clinical trials to determine that difference, by using PET imaging for that as well.
So there are a lot of other questions I have here about like the advances in proton therapy benefiting breast cancer patients, particularly those with brain metastases or other complex issues.
Proton therapy in the metastatic setting for breast cancer, there's really, I would say, there is not a direct indication for that. And if anything, it might be used in the setting of reirradiation, but even that is rare. Um, so protons are not the primary treatment of choice for metastatic breast cancer.
Okay. Okay.
Certainly they can be used. Certainly they're appropriate in certain situations, like in the setting of reirradiation. Let's say you're treating a bone metastasis and it's right next to the spinal cord, and the spinal cord is seen as much as it can tolerate.
Mhm.
Protons can help avoid the spinal cord, but still treat the tumor.
Okay. Okay.
That kind of
Um, why don't you just say
thing.
one last closing thought and we'll try to regroup.
Okay. So I would say that the treatment of stage 4 breast cancer is challenging. It's emotionally challenging and it's clinically challenging. I think it's important to know that the primary thing that patients would receive treatment for with radiation are metastases that are causing symptoms and affecting quality of life. Stage 4 breast cancer is still not curable, but not curable means that we can still have patients live for many years as long as we're able to take care of their tumors and their symptomatic tumors.
Okay.
What we're hoping to do is to treat metastases before they become symptomatic and be able to treat them with a high dose of radiation so that they remain quiet for many years.
Mm,
And that's our goal. So
that's awesome.
I think that that has been very rewarding and very helpful towards patients. But looking forward, I think that radiopharmaceuticals will allow us to further treat breast cancer patients and treat them with the potential to really control their systemic disease for a long time.
Mm,
And that's hopeful to me as the future of what we can do for patients with stage 4 breast cancer. And I think that it's coming and it's exciting, and it will help us both with imaging and being able to
mhm.
tell how the treatments that we're delivering are working, and it'll help with actual treatment by delivering radiation through the bloodstream instead of from a machine.
It's incredible. Okay. I'm excited. I'm excited for you. It's cutting edge.
Isn't it
And I
cool?
can't, yeah, it's really
Yeah,
cool.
it's
Can't
so
thank
cool.
you enough.